How are you doing, Richard? Everything good?
I'm very good, thank you, Douglas. How are you this afternoon?
I'm very grand, thank you. It's a beautiful day outside, and we have a great guest to share conversation with us.
What's exciting today, I think, is we're coming at this from almost a different routine. Maybe that's the way to look at it.
Yep.
We're going to start with John, obviously understanding who he is, what he does, but looking at a project that they've been working on and what do we learn from that and what came out of it. And that's a really practical way of looking at this. So I'm really excited about today.
So to no further ado, let's bring in John from Care City. John, how are you doing?
Hello, Beth. I'm very well, thank you.
Good to see you,
thanks
John.
for having me. As you say, John Craig, Chief Executive at Care City. We are an innovation centre for healthy ageing and regeneration based in Barking, co-founded by the London Borough of Barking and Dagenham and North East London Foundation Trust. Hosted in the hospital for a period, and now spun out as an independent community interest company. We have about 12 people on our team, and we work across research, innovation, and development, which is really our theme, focusing on workforce and regeneration. Our work is about transforming health and care services, but also trying to make a significant difference to the determinants of health in East London and in London's poorest borough, and showing that better care can help to transform a city like London.
And John, that mix of a local authority and an acute hospital trust must give you a much wider perspective than many people would normally have, mustn't it, having those two stakeholders on board?
I mean, I describe it as trying to have our cake and eating it. It's about being a social enterprise, but also having a foot absolutely inside the public sector with these ready-made public sector partners, our co-founders and their partners too. So I divide my time between running our social enterprise, but also serving on leadership forums of our integrated care system. And it says in the terms of reference, innovation partner. And that notion of an innovation partner to an integrated care system, I think, is really exciting and powerful. And you're right, it does give us that breadth of perspective of, if you like, the independent sector beyond the public sector, but also understanding how we can work in partnership with those incredible leaders and clinicians in East London.
Does that make you, gosh, I was thinking at first when you described it, you're subject to them, but actually I get a sense of you driving agendas in there as well. It works both ways, doesn't it?
It does. I mean, so I think I have to wear on my sleeve in that partnership that I have no formal authority, decision-making power. I sort of hold a budget, but on a good year, it equals my expenditure. So we are subject to them, but part of what we want to do is to attract to East London new ideas, innovations, resources that can help to make a positive difference. And so at times that gives you a little bit of leverage to say, because you think, well, what idea or what innovation are we going to introduce? What partnerships can we broker? And so of course, yeah, we're trying to shift the needle for the better, but always conscious that it's an absolute privilege just to be around the table, and we can really only mess those relationships up once. So I guess we do that really cautiously.
Yeah, thank you. And
it's refreshing that you have that sort of relationship. What do you do to actually cultivate the environment whereby those bright ideas can be worked upon? What's the process for doing that?
I mean, you can read lots of innovation articles, can't you, about building the right culture. And of course, I think it is about being honest, about not being scared to try things safely, and being open to failure. I also think it's about building a social business that depends on finding new ideas and building a reputation for being able to test them rigorously and safely and scale those to succeed. So I genuinely wake up every day excited to work for Care City, but also a little bit worried about where's that next idea coming from, where's that next project coming from. And I don't think there's much of a substitute for the urgency that comes with a business that has to chase its mission to survive and thrive. So I think it's partly that culture, but I think it's partly, that's what Care City does. That's the job.
Yeah. John, just if we can get into the specifics then of this project you were working on and what it started to illuminate for you. Can you give us a bit of background and then
Sure.
the journey you went on, please?
So I didn't create Care City, but I am their first chief executive, because I arrived shortly after they landed some big projects. And they thought, oh, fantastic, we've got a big project. Oh, day two. Oh. So my first day in the job was in an office of NHS England, trying to explain why I tested so few gadgets on so few people, as part of a big innovation program called the Tech Program, which is run and funded by NHS England and the Office for Life Sciences. It's about taking high potential innovation to proven better outcomes and experiences at lower costs. And that was a fantastic opportunity, really, for Care City. We set out a whole portfolio of different interesting gadgets, if you like. And the exam question was, what pathways and systems can these transform for the better? And so just to give you a sort of feel for what that program was like, and also how Care City has evolved, I thought I'd tell you about just one of the innovations, which I think won't be news to many people, but I still think it's interesting and perhaps still underused. We worked with a company called AliveCore. They have a product called Cardio Mobile, which is that credit card sized ECG that talks to a smartphone or a tablet, and it can screen people for likely atrial fibrillation. It's not as good as having a 12 lead ECG, but it's pretty good. If it says you've got likely atrial fibrillation, get it checked out. As I say, it's not novel. Simon Stevens took them on the One Show. So we are beyond peak cardio, right? It's old news, but it was important news for Care City. So we said, look, first of all, let's test 100 things. Let's just play around with it. Like they do on Dragon's Den, where they just try and break it. Let's just mess around with it and test it in lots of different places. One of the places that we tested those devices was in high street pharmacies, seeing if we could screen over 65s and spot likely atrial fibrillation. And we could. It kind of works really nicely. I mean, people come in to get their repeat prescriptions. As you look at their age and you say, oh, Richard, gosh, you don't look over 65, but as you are, would you like a free heart check on the NHS, right? Just flow, it just works, and it's quick and it's easy, apart from because it's a pilot, you've got to fill in forms for 20 minutes, but let's pretend it's not a pilot. It's really smooth. So we did that and it worked. But what we ended up doing was sending lots of worried people to their GP, which, GPs are busy enough already. It's really great for them to have lots of unmet need banging at their door. But as a system, and this is the innovation partner, this is sitting around with GPs, pharmacists, secondary care specialists from Barts, commissioners, really racking their brains. We said we can do better. So we built a prototypical AF pathway that involves screening in high street pharmacies, but then a direct referral to ideally one-stop appointment in Barts Health. So direct to secondary care within 2 weeks. So you've got to go for a blood test in that 2-week window, then go to Barts, have all the tests, get your diagnosis confirmed, and get some treatment issued to reduce that very high stroke risk associated with atrial fibrillation. So we did all that, got the pathway going. We brought all the pharmacists in. We gave them amazing East London curry, brilliant training. They stuck around for 3 hours. They did a great job. And we even had one of those proper OSCE exams at the end. We felt great. We've done a really good job. And they went back to Waltham Forest. And this isn't fair because it was great working with the pharmacists, okay? But my version of this story is they lobbed those gadgets at their counter assistants and said, look, it's dead intuitive. Can you do some screening, please? I've been trained, it'll all be fine. And of course, it wasn't all fine because people are incredibly creative in ways to mess up using a piece of technology they haven't been trained. So we had all kinds of errors in the system all over Waltham Forest. And my amazing colleague, Simran Janjua, who happened to be a pharmacist, which gave her a lot more credibility than me, drove round Waltham Forest as a mystery shopper, catching people out for all their mistakes and sort of retraining them there and then in the shop, one by one. And that was a big deal for us because it was a mistake. And people talk a really good game about mistakes in innovation, don't they? They talk about failing your way into success, and we should celebrate mistakes and I sort of get that. I mean, it's just that the number of things that won't make public services better is infinite. So if you're trying to go through the things that don't work one at a time, it's going to take you a while. And as we all know in public services, you don't have to fail very often before you've used up the oxygen of trust and legitimacy, right? So I think the point that really matters is if you mess up, admit it frankly, learn from it and do better. That's the discipline. I'm still not quite there to celebrate it. But it was important for us because we said these counter assistants are interesting. John didn't really think about the counter assistants, but they're pivotally important. And we're an innovation centre for healthy aging and regeneration. And these are generally young people, although it is a mix, who've got a job in a shop. They could be working in the newsagent next door, and a little gadget just meant that they might have helped save a life, which is interesting for that older person in East London. And it's interesting for that counter assistant, isn't it? So what did they think their career was going to be? Did they think that they were good enough to work in the NHS, to be part of our health system? I bet they didn't, because young people in East London think that the health system is doctors and nurses. They're incredibly special people, and most people don't think they're special. So that mistake has actually been pivotal for us, thinking, isn't that interesting that a new piece of technology has changed the capability of what a counter assistant could do? They don't really change the capability of a cardiologist. They could give you a better ECG than that device can from the golf course. They are amazing already. Okay? But for a counter system, it made them dramatically more capable, and it was inspiring for them. And so we've more and more now, as an organisation, focused on projects like that, where we can combine a digital innovation with a workforce innovation to unlock benefits simultaneously for the patient or the service user and for that member of staff. And there's no accepted term for who we're focusing on, but they're just people who aren't paid so well in our health and care system, and generally aren't so skilled across such a broad range of areas. So they might be administrative staff in a hospital, receptionists in primary care. And actually, we've done a lot of work in social care now, thinking about both care home staff and home care staff who do a huge amount of incredibly valuable work around personal care and support, but aren't really yet the eyes and ears and hands of the health system as systematically as became the case for those counter assistants. So thinking about how digital innovation and workforce innovation can work together to transform some outcomes, but also transform some careers and tell a story about how to regenerate a poor part of East London. That's sort of become what Care City is about. And to an extent, it came from a mistake, although I would say it came from the admitting of it frankly and trying to learn.
No, I think that example is fantastic, and I just want to talk to you about the mindset again. You talked about this being a mistake, and I think it's a journey. It's a must-take journey, and you managed to untap value in a workforce that was underappreciated. Is this something that you fully embed moving forward as part of the transformation or road journey, as it was, to seek out these groups a lot earlier and bring them into the projects?
Yeah, I mean, first of all, I think you're right that probably seeking to implement complex innovations does involve inevitably some mistakes and some learn. And I know that for leaders and certainly politicians, there's a frustration that great innovations don't scale and become adopted quite as quickly and uniformly across our system as they should be. I think that there's a lot of truth to that, but we do have to remember that all of those adoptions and implementations are themselves creative acts and give people the space to do some of their own learning in the process and help them expect that to be part of the process. So I think that's important. And yeah, absolutely, that is now a really strong theme for us, that it is easy to underappreciate the significance of support staff in all different guises across our health and care systems. I actually think the COVID-19 experience has also helped to shift the dial on some of that. If you're a GP who is locked down, that's an incredibly stressful thing for a GP to deal with. I think you're just in survival mode, trying to look after your patients, aren't they, in a way that you've never had to before. And so any assistance you could get from health or care colleagues who are boots on the ground, if you like, a home carer in someone's living room worried about their health, then I think you switch on to that more so than ever before. So I think increasingly this is a language that senior clinicians are learning to speak. They're sort of learning that they actually lead a virtual team that's getting bigger, and that helps them a great deal, but it brings with it lots of leadership challenges. And I think digital innovation and workforce innovation will play a big part of that. If you like, I can tell you about some of the things we're doing in care, sort of off the back of that. But there is something really important about the moral, that really remembering just how many people work in care, absolutely enormous workforce, and that each one of those, has done an incredible job, and is able to learn and develop and do more, is a really important ethic for us.
Sure. I remember we were doing a remodeling exercise in the trust I was working for before, and we spoke to some patient groups and to ask them, who is the most important person to you? Bear in mind, this is a mental health trust. And, we were like literally thinking they would say, the psychologist, the nurse, and it turned out to be the receptionist. And then we had a view that maybe if you uptrain the receptionist, they can also add value. So how much of this work that you're doing, are you seeing it being technology driven or human unearthing of the human potential?
I think it can't be technology driven, partly because that isn't right. That too easily takes you into slightly misanthropic space, but also I'm not a clinician. I'm an overgrown politics student, and so the exciting, and I faint at the sight of blood, okay, and I'm ashamed to say it, but it happens to be true, and everyone near me needs to know. So I can't do this on my own. Yeah. I can only do this by getting alongside amazing clinicians who say, "Oh, that's interesting." How often home care staff and district nurses pass each other on the doorstep like ships in the night. The NHS spends £8.3 billion on wound care. That's like nearly half the entire budget of social care. I wonder if there's a way that district nurse and that member of home care staff can collaborate. Now, I might be able to have that insight thus far, but what the form of that collaboration might take years down the line is beyond our ken. And I think the challenge to social care colleagues is to say, absolutely, sort of, hopefully kind of take what I'm saying, which is everyone in social care is incredible, they can do more. But let's also not be too tribal in care and say, it's okay for health to lead on some things because they know about some stuff. When you can work remotely with a physio or you can get MDT support in your care home, it's incredible, and the clinician can lead on clinical questions, and everyone can benefit. So I think it has to be clinically led. It has to be led by the evidence, and it has to be tested carefully. But what's undeniable is that because they're being produced en masse for the consumer market, every month an interesting new capability emerges that's smart, easy to use, cheap, mobile, and we get excited about middle-class patients using it, frankly. If they can do it, every single person in our health care system can use it for the patient they're standing next to or the service user they're stood next to. And to me, there's still more that we can do to realise the potential of those innovations for our least trained, least well-paid staff.
And what you're saying in here, though, is that the workforce that's available to us in a world of a shortage of healthcare professionals, as we used to talk about them, in your world, that population is enormous, because they are people anywhere and everywhere, every corner you turn.
Well, I'll give you an example, partly because it's taken me 2 years to make it happen for only 4 people, so I need to tell you. We have been looking at apprentice nursing associates and nursing associates. If you ask residential care homes who don't have a nurse if they'd like a nursing associate, they say, yeah, I'd love one. That'd be really useful because I haven't got a nurse. And of course, as it stands, they can't have one, because an apprentice nursing associate, rightly, is apprenticed to a nurse. So there's just a lovely catch-22 problem. The people who most want one can't have it. But acuity and complexity in care homes is rising all the time, and it's really high right now. And more, care homes are being digitized. There's remote consultations going on from that care home to a GP or to a hospital, maybe some remote diagnostics. Alongside that, we need to think about the workforce innovations that supports and enables. And we've been working with a huge long list of partners, but including University of East London and North East London Foundation Trust, to provide some remote supervision to support members of staff in those care homes to become apprentice nursing associates, just as they might if they worked for the acute hospital down the road. And I think that's an interesting example, because there are already key members of staff who can liaise with those district nurse and GP colleagues. And of course, they want to know if they're in the building, because they don't want to miss a bit of clinical practice they could observe, right? That can go on their record. So they're taking a load off for their managers. They're driving a lot of those new routines around remote monitoring. So when the GP comes on for their weekly virtual ward round, they're not just a face being carried around a care home on an iPad, which is a pretty daunting thing to try and make sense of a clinician. They've got a dashboard. They can say, right, I want to talk to these 5 people. But they can also talk to that apprentice who's clued in, who's part of that clinical routine, and can help them translate action and next steps into reality, in terms of the routine of the care home. So again, that's lovely for the GP. As you say, saves them some time, and they haven't got much time. And even if we want more GPs, we can't have them tomorrow. It's hopefully good for those residents. But for me, it's great for those members of care home staff, because the story about progression in social care is, well, you maybe become a manager and then become an owner. And that's either unrealistic or unattractive to a massive proportion of those people. And in East London, some of those staff were a nurse in another country, and they just can't find a route in for a career based on clinical skill. So let's unlock it for them. And my point is, digital tech doesn't drive this, but it's the missing bit of the jigsaw of constructing some different stories about how we work together, how we save some time of exhausted, hard-pressed clinical staff, and build some different career routes for our staff.
Thank you.
We're going to have to break. We're well over. We're going to be in trouble with everybody for running over. But that reflects what you've provided the way of insight today. I don't know if in a 20-second burst you can say, look, these are the 2 things, one thing that people should just bear in mind as a takeaway, just to wrap us up, which feels unfair given the scale of what you've covered. But
in your health and care system, wherever you are, there is a lot of clinical leads thinking about remote monitoring, remote diagnostics, remote supervisions, and taking a lot of the expertise of hospitals and the health system and getting it out there into our community. There's another set of people who are thinking about quality and workforce challenges out there in primary care, in social care, and they are your allies. If we could bring those 2 groups of people together, I think we have a better chance both of improving outcomes for patients and for changing the lives of some of our most hard-pressed staff.
Thank you.
Thank you very much, John. Thank you very much. Very informative. Thank you.
Pleasure. Thank you.
Thank you, John. So there are so many things I could pick out from that in terms of, I think, mindset. That whole thing about the volume of people in the community that can help, and your organizational focus on the community sort of struck me over and over again. sensitive to the community, touching base with the community, using the community. God, I don't know. I don't know what you reflect on that. Is that at the heart of what you do, Bruce?
I mean, we're doing some work actually with a really clever spin out from UCL called Sotalia, who do the maths of optimization. They do the maths of Tesco giving you your delivery slots online. And we've been looking at the scheduling of home care and healthcare at home. One of the insights they've come back with is, we think we know why there are so many very small home care agencies, because scheduling that team of people on a piece of paper and in your head is so difficult that it's sort of impossible to grow beyond a certain size.
Yeah.
I mean, which I feel like I want to press pause in my career and do that PhD to see if it's true, right?
Yeah.
But it might be true. It kind of rings true. And I just loved it as an example of exactly what you just said, which is there are some really practical, logistical bits of furniture in community healthcare and social care that we take for granted, but they probably massively condition what's possible for staff and service users on the whole system. And if we could just make them better, a whole world of possibility would open up. And I think that is what I'm excited about.
Yeah, I think you're doing fantastic work. And for me, it does seem that Care City is the epicenter. You're generating your own gravity by pulling organizations, teams that would generally not communicate to each other to have conversations and add more value in the community space. So we've got a question here regarding what sort of potential projects might be explored in the coming months. Anything else that you want to share?
I am really excited about the wound care strategy. So the work that's being done nationally, connecting up with some fantastic academics to sort of pull together, we're spending £8.3 billion on wound care. Gadgets like Healthy.io, who we've worked with in the past, helping people to do a lot of that sort of simpler end of work around checking wounds and checking that they are healing appropriately. I think that's a big issue for community staff and potentially social care staff. And if we can do that, we could help to automate that process and provide a whole platform of support for very, very hard-pressed district nurses and tissue viability nurses. I do think that's a really exciting area. I also think that we've learned a massive amount from COVID. And I think a lot of our next 12 months should be about trying to unpack what have we learned from the fact that we can vaccinate people in theatres and cinemas and football stadiums. We can do pop-up healthcare. So what should we do with it? We employed a whole set of people in those centres that never worked in healthcare before. What could we do with them and for them? Equally, we've built a whole set of new pathways around home monitoring to help get people out of hospital as soon as we can to make space for some others. We only did it because we had to, but we are actually right now transforming our remote monitoring capability. How do we manage that so that just doesn't create more demand for the health system? How do we manage that to really start doing what we've been talking about for a long time around personalised, proactive healthcare? So I think there's a sort of specific around this wound care strategy, and then there's a general theme, which is I think we've learned more than we realised from the chaos of the last 18 months. And there's a sort of whole world of benefits there to be realised if we can just take a moment to reflect on how far we've come.
Excellent.
Thank you. I've got another question. What's the best route for digital health innovation to get traction in the community? It's a tricky one, isn't it? That's your bread and butter for you. It's tricky for the rest of us, but
I mean, we work really closely with UCL partners. We were co-founded by the London Borough of Barking and Dagenham and North East London Foundation Trust, but UCLP were there sparkling some stardust on the process. It wouldn't have happened without them. And I do think that AHSNs are a really important broker in that context. I also think when I meet innovators, for the want of a better phrase, one of the questions I ask them is, whose job does this transform? And a surprising number of them say, well, I mean, loads of people's. I mean, basically, we should reorganize our whole system around my gadget. Which, which I get, right? You're excited about your gadget, but you also haven't been curious about the rest of the system or the pathway. So really, it's sort of my mistake about the counter assistant. Don't make that mistake. Understand whose job this changes, and that will really give you traction.
Sure. And does that follow through within that narrative of those benefits of who this innovation is for? Does that follow through on the business cases? And are you finding that because of so much innovation at pace, are you scaling back on the depth of how big a business case traditionally is to get all these signed off?
Yeah, I think so. I mean, probably you're thinking of the same kind of patterns of experience as me, which is it's pretty rare that by the end of the business case process, the result is that this works for everyone. When you say to someone, what kind of patient is your digital tool for? They say, well, everyone really. Immediately, again, kind of question marks go off in my head, which is that would be incredibly unusual. Like a smoke alarm is for everyone, isn't it? Pretty awesome. There are developments like that, but they're pretty few and far between. So being really clear about whose job it changes and which patients' lives it changes, understanding it's unlikely to be everyone from a business case perspective, Douglas, I agree, is really important.
Thank you.
And what struck me throughout this, John, is you're an enthusiast, you're passionate, you believe, and people benefit from that, and that gives them energy to go off and do stuff. But not everybody has that passion, belief that you've got. So how do we get mass movement adopting the sorts of things you're doing? How do they, when there's someone out there in your patch that hasn't actually touched you and experienced you, but you need to get them on board, how do you get that to work?
Well, I think that is a sort of ignoring the bit about me. I mean, they could work with anyone on my team and have a better experience. But I think that is a very, very difficult question. I mean, often, actually, we've seen this more in education. You do randomized control trials of complex interventions into schools. So you have to randomize schools into the ones who don't get to do it and the ones who do. And so you can't really have the ones who are really passionate because they're not willing to take the gamble that they have a 50% chance of not being allowed to change anything for 2 years. So essentially you have a process that controls out passion. And in my experience, it's really hard to make the kind of interventions I'm most excited about survive that kind of test, because passion is sort of an essential ingredient, and yet no one has it on tap. So I think that is a really tough question, Richard. I think all that social science has to teach us is there's no shortcut to building a movement. If you think that the kinds of solutions we've been talking about today are going to go viral in any meaningful sense, you just haven't been working at it very long. So all we can do is keep making friends, keep making allies, keep going back to the reasons that we do this in the first place, and being generous to each other and helping one more person in your day, and we can get there. But yeah, I don't have an easy answer to that question. It's a big challenge.
Yeah, there's so much of this is about perseverance, isn't it? So much of it is you just got to keep going and keep believing, and you don't know when it's going to get traction or how or what's going to trigger it. And I think in a way we dream that it will our first time out, but it's so rare.
Yeah. I think, John, you said something that struck me in the conversation about living up to your own mandate, your own mantra, as something that drives you and your organization forward. Could you just say a bit more about the mantra or the mission statement for Care City?
Yeah, so we talk about a happier, healthier, older age for East London being our mission. And sort of, I think happier is important in that, because it just makes it even clearer that, if we had a 4-hour standard for primary care, our hospitals might be happier and so might everyone embarking. but it's not going to change their lives. They don't have to hang around embarking very long to know that better access to some doctor's appointments is not the world going to change on its own. So, you know, we always try to ask ourselves really tough questions before we take on a project about the relationship between that project and our mission. And one of the simplest ones is this going to affect health and the determinants of health? See previous question, in a very small way, right, if we're honest. But we're always trying to do both simultaneously. So that's the sort of theoretical part of the answer. In practice, the watchword for our team is relentlessness. Because we are, you know, sort of insider outsiders, but we are outsiders, and it's very easy for us to say, well, I've sent that busy doctor an email, so hopefully that will be all right. And, you know, 9 times out of 10, it won't be all right, will it? Get on the phone, go and knock on their door, because they are literally down the road, and make them your friend. And I say it a lot now. It's got into the world. Every time I interview someone about working at Care City, they now tell me that they're relentless. So I must have said it somewhere that people have picked up on it. But I think that that sort of relentlessness. I really love sports, so my heroes are sort of slightly sort of mindless sports people who just keep going regardless of how much pain they're in. And there is a bit of that relentlessness that you need.
Yeah. We've got one last question, and we could just sneak it in if we could, and then we're going to have to break, so we're well over, and Catherine will tell us all off. With technology evolving at such a fast pace, thanks to Jinder for this, with technology evolving at such a fast pace, what can be done to train and educate healthcare professionals to engage and keep up with the pace of innovation in healthcare? So how do we help our healthcare professionals keep up with so much that's going on? And not just keep up, I guess, it's actually get on, adopt and use.
Yeah. Well, I think that's to Ginger Baines, who is from our neck of the woods in Havering, and runs one of the care providers, Care Plus, who we've worked with. So thank you to Ginger for your partnership, if not for your challenging question. I think we have had a sort of a model of working and learning, where learning is something you do before you start work, or sort of on a Friday when you're not working, or a Monday, you know, you have time away, and that just isn't sustainable now. We need better learning embedded in people's daily work. So we need to make better use of digital tools, better use of mentorship, supervision, coaching as part of people's daily practice. And actually, at the moment, we're also investigating use of VR for things like work experience, because there's never been enough space and time for work experience for young people. And now, because health and care has been in the news for 2 years, demand is higher, and there's even less space for it. So we are going to have to use, I think, qualitatively more technology and dramatically greater commitment, both to partnering one another and to growing the workforce of tomorrow, because all of us know that actually the biggest risk facing the health and care system is sustaining the workforce we've got, and attracting the next one. So it's a really important question, and everyone leading the health and care system needs to know it's not marginal, it's not a support system, it's not one of the enablers in the last chapter of your strategy you didn't write very well. It's the ball game. So it's really, really important.
Thank you. Douglas, over to you to close, if you can.
All I can say, John, that was a journey that I didn't want to get off the train. So much great insights I think everybody will applaud and celebrate and learn from, and try to apply that practically in their own organizations. Again, living up to your mantra. Don't just have a mantra for no reason. Live up to it, connecting people, engaging in exciting projects, and being relentless. So we shall continue relentlessly banging on the drum of thinking big and acting now. Thank you very much, John and Richard, for your time. Have a great evening, guys. Take care.
Thank you so much.
Good luck with everything. Thank you. Bye-bye.
Superb.
Again, where do we keep finding these people from? They're marvelous.
Do you know what? Yeah, it was. Do you know what? My biggest challenge was, how can I get a question in? Every question I had formulated in my mind, John was actually talking it through anyway. So I was like, okay, think about something else. So no, it was good value. The challenge, I guess, is to edit that down into a concise piece of content that we can distribute. But no, I loved it. His example is excellent, and that whole partnership approach between a social enterprise and a trust. You know, and obviously your journey as well of HCI. You know, this is right in your ballpark of some great opportunities emerging and being able to shift the dynamic, shift the conversation outside of the traditional way of working to bring value. I'm learning a lot from you and the guests on in terms of just how meaningful it is.
He was just amazing, just phenomenal. So, what stood out to you then from what he was?
What stood out for me was John talking through about untapped capabilities in staff. You know, seeking out people that are part of the team but marginalized, that are not at the dinner table.
Yeah.
And then when you're doing your transformational piece of work, you don't include them, but they're part of the inherent team. And then making them feel valued, you know, which I found that refreshing and very insightful. It takes a curious mindset to think outside the box for that.
And I think that's what struck me throughout was curiosity. Almost every turn, he, like all of us, faces issues, challenges, but he was just of a curious mindset. He never stopped going, well, what about, could we look at this differently?
Yeah. And it was upbeat. And I think that's what we need. To talk about energy. Right at the beginning when it kicked off with Lisa Hollins from NHSX, that energy, and people in these positions need to be able to absorb some of the perceived negative outcomes from innovation and reframe it to energize the team to say, no, come on, but what did we learn about this mistake? And then do something about it. You know, they're not, like I said, the next day you come back and it's another day, back to the drawing board. And I really like that approach.
Yeah, no, absolutely fantastic. Just created opportunities everywhere. Fantastic, man.
Brilliant. So I look forward to more conversations. Richard has been excellent.
A pleasure as ever. I will see you later on.
Indeed, 2 o'clock.
2 o'clock for Adele. Here we go.
Yeah, that's going to be brilliant as well.
Yeah, she was good. So we've collected some people here, Douglas, I tell you.
Yeah, do you know what? It is the conversations that keep on giving. It's them taking a look when it's all done and taking a step back. I think we can all be proud of ourselves. So do you know what? That is a good, solid piece of work. You know.
What was striking me during the call was how, I know we're all doing our utmost, but how we get more people accessing what the likes of John and Jono and Adele and Lisa are saying, because there are invaluable messages for everyone. You know, you as part of it, it should be as a manager, supervisor, leader, consultant, director, whatever your title is in health. They're the things that you should just have, not because they're necessarily the answers, but they can stimulate your thinking about what are the answers in your circumstances. And I don't think we'll reach enough people, and that feels wrong to me.
You know what? Our work, which is not, it's a life's work.
Okay.
You know, and I think,
all right, you're on.
To start it off, it is fantastic, and I'm with you 100% on that journey. This is why I think John was talking about education was so important, because we're talking about re-educate a system. You've got people in strategic positions that have gotten that position for thinking a particular way. Yeah, and they're still in post. So without re-educating them, it's going to be more of the same.
Yeah, okay.
You know, and then we've got newly qualified personnel coming in that will inherit maybe old ways of working, but with new technology. They need to be educated. You've got patients that are used to being a patient, i.e., our matron knows what's best for me. They need to be re-educated. No, you got a Fitbit, you got this stuff, you can monitor yourself. So there's a lot of this requires all what we are doing, I think, is we're starting the conversation. We're part of the journey, part of the solution, and I look forward to.
I'll stop beating myself up then. You're
right.
right.
You're doing an excellent job, Richard. You're doing an excellent job. And I think the line of inquiry is so good. It's measured. It's well thought out. I just want the output to be something that we can build.
Keep building on.
Yeah. No, thank you. Thank you very much.
Right, mate.
All right.
See you later on.